So here we're going to go through a primer on brainstem anatomy. Brainstem and cranial nerve anatomy are the two toughest sections in neuroanatomy, so our goal is to create a roadmap that will allow us to predict where these various detailed structures live. We're going to walk through a composite of the brainstem, and then we're going to see how it applies to the midbrain, pons, and medulla, and then we're going to test our understanding of this going through classic pathognomonic syndromes. This is the sagittal view of the brainstem here, and we're just pointing out some key surrounding structures. All of these have the potential to cause compression of the brainstem. Clearly a cerebellar stroke, for instance, one of the great worries is compression in this posterior fossa on the brainstem. Pineal gland tumors can come down and cause compression on the brainstem. And then we've seen how the medial temporal lobe, the uncus, can herniate over the tentorium cerebelli and compress the exiting third nerve in the midbrain itself. So from top to bottom, the midbrain, here's some key structures of it: cerebral peduncles, the colliculi posteriorly, and then we point out the posterior commissure. When it comes to the pons, we always like to talk about this bulbous basal outpouching with these large pontine nuclei and pontocerebellar fibers living within it. And then here's the medulla here, and we can see how the medulla is really just an outpouching extension of the cervical spinal cord here. So this is our axial view, and it's worth getting oriented. It's worth learning this, because when you understand this well, you're going to be able to apply this information to all levels of the brainstem and predict the anatomy. So this is anteriorly, this is posteriorly. We've split this to represent nuclei over here and tracts over here. There's a basis, a tegmentum, and a tectum. At various levels of the brainstem, various sections are larger than others. For instance, as we pointed out, in the pons, there's a very large basis here. So the first section, we're going to talk about major motor tracts. They live anteriorly, and that's what we point out here. Key motor tracts include corticobulbar, so innervation to the face, corticospinal tracts, innervation to the limbs. Major sensory tracts live posteriorly, and we see that here. Again, key ones: medial lemniscus, spinothalamic tract, and then the trigeminal thalamic tract. Now notice how this parallels the spinal cord. In the spinal cord, we talk about motor anteriorly, and we talk about sensory posteriorly. Supplementary tracts, we're looking for posteriorly. So if someone's thinking about the central tegmental tract, rubrospinal tract, reticulospinal tract, if that's what you're trying to identify, this is where you're going to look for it. You're going to look for it more posteriorly. Cranial nerve nuclei, again, live posteriorly. So if you're looking for cranial nerve nuclei, you don't want to be looking up here in the basis, you want to be looking posteriorly. Finally, supplementary motor nuclei, such as the red nuclei, substantia nigra, pontine nuclei, and then in the medulla, the inferior olive, they're going to live anteriorly. So that's where we're going to look for them. So now let's, and just not to forget the neurobehavioral cells. So each level has these cells. We call them neurobehavioral cells because they have an identifiable neurotransmitter that's going to have an important behavioral function. Examples: periaqueductal gray in the midbrain, opioid activation, serotonergic activation, the Raphe nuclei, important important serotonergic nuclei stretching the vertical axis of the brainstem. Locus ceruleus, important adrenergic center in the pons. You're going to be looking sort of more in the middle portion, posterior portion, the brainstem for these neurobehavioral cells. So let's test this out with the midbrain. We'll talk about cranial nerves second. First, we're going to talk about these tracts and nuclei. So cerebral peduncle here is carrying major motor tracts, and look at where it is. It's anterior. That's where we said it should live. It's going to carry those corticospinal, corticobulbar tracts. Supplementary motor nuclei, the substantia nigra and the red nucleus, they live, again, anteriorly. That's where we expected them. Periaqueductal gray is posteriorly. That's where we said the neurobehavioral cells would be. And then the colliculi, which are auditory and visual integration nuclei, are sensory, and they live posterior here. Now, obviously, they are interacting in motor components of things, but they are major sensory integration centers. When it comes to the cranial nerves, something we didn't talk about earlier is that the motor cranial nerves are going to live medially, and the sensory ones are going to live laterally. So at the midbrain level, you have cranial nerves 3 and 4. Motor-wise, their components are going to be medial, and then the mesencephalic extension of the trigeminal nucleus is going to be out laterally here. So in the pons, pontine nuclei are these major supplementary motor nuclei. They live anteriorly, as we anticipated in the pontine basis, along with these pontocerebellar fibers. Again, when it comes to its cranial nerves, the motor components of them are going to live medially here, 6, 5, 7, and then the sensory components of things, the principal sensory nucleus and the vestibulocochlear nucleus, are going to live out laterally here. Finally, for the medulla, we talked about the inferior olive as a major supplementary motor nuclei. Look where it lives anteriorly. And then the medullary pyramids carry these descending motor tracts. It lives anteriorly. And then the sensory nuclei, major sensory nuclei, live here posteriorly. Cuneate nucleus and gracile, the leg fiber nucleus. So sensory posteriorly, motor anteriorly. And then once again, the cranial nerve nuclei follow this rule of the major motor components, 12, 10, 9, all are medial here, whereas the sensory portion of these cranial nerve nuclei are out laterally here. So now we're going to talk about major projections. So these are the ascending and descending fibers as they go from the cerebral cortex, the spinal cord, passing through the brainstem itself. We'll talk about motor first, and then we'll talk about sensory second. So with motor, we're talking about descending fibers. So here's our motor homunculus. Remember, the leg lives out medially, and the anterior cerebral artery, the ACA, covers it, whereas the arm and face live out laterally here, and the MCA, the middle cerebral artery, covers it. So in an MCA stroke, the arm and the face are going to be affected, but the leg should be spared. Now we demarcate with this little orange X here a twist. So these fibers will, for lack of a better term, twist, and they will change relative positioning when they do. So the leg fibers start out medially, but when they hit the internal capsule here, there's a shift, there's a twist, and the legs now move out laterally as they descend the brainstem. So they're medial in the cortex, lateral to the arm fibers within the brainstem. Then there's this decussation where they actually cross sides of the body. And when they cross sides, they end up, there's also this twist that we see here at the medullocervical junction. So ultimately, as they cross, as they decussate, the leg fibers move from lateral here to lateral on the other side here as they make this twist. And then the arm fibers come down, they cross, and when they cross, there's another twist, so they end up medially here. So we talk about this in the spinal cord, but when we think about syringomyelia, as it's expanding out, it's going to affect the arm fibers first because they lie medial to the leg fibers within the spinal cord, but that is the opposite than what we see here in the brain, where the leg fibers begin medially. When it comes to sensory pathways, this is the end point of this is the termination. They project out from the thalamus here. The homunculus, the motor and sensory homunculus, is the same. The leg fibers are medial and the arm and face fibers are lateral. This is the final twisting that they do as they project out from the thalamus. This is the trigeminal thalamic pathway. It enters and crosses immediately like the spinal thalamic tract of the spinal cord. And then this is the anterolateral system or spinal thalamic tract. Remember, when these pain temperature fibers come in, they may go up and down some levels, but they cross immediately. They don't ascend the spinal cord, they cross and then they ascend. And that's in contrast to these posterior column fibers, these large sensory fibers, which come in, ascend, synapse in the cuneate and gracile nuclei here, cuneate for the arm fibers, out laterally, gracile medially. Then they twist, they form a twist as they decussate. Then they hit the thalamus, and then they twist again. So the leg fibers come in, they synapse medially within the brainstem here, twist, and then when they twist in this decussation, and then they twist again to land medially here. And we can see this decussation and twisting here. So the cuneate nucleus out laterally, gracile medially, decussation, a crossing as they ascend up the medulla, and then a twisting as well. So as they ascend the brainstem, these arm fibers are medial, and then there's a twisting as they project out from the thalamus here. So now we can challenge ourselves with these various brainstem syndromes and see if we can anticipate the localization of the anatomy and the clinical manifestations. So when it comes to the midbrain, this is a myelin-stained cadaveric section. We can see this Mickey Mouse ear appearance of the midbrain with the red nuclei here, and then the cerebral peduncles carrying those descending motor fibers. And this is the section of the brainstem that we're focusing on there. So there's going to be three different midbrain syndromes that we're going to walk through. Weber syndrome, localization here, anteriorly, medially. So it's going to affect the crus cerebri, the descending corticobulbar, corticospinal tract fibers here, because corticobulbar actually lies medial to the corticospinal, which is more lateral. And then it's going to affect the exiting third nerve. So you're going to see an ipsilateral third nerve palsy, and then the side of the body that's going to be weak is the opposite side, because these descending motor fibers are going to carry fibers from that will ultimately innervate this side of the body. So contralateral weakness and ipsilateral third nerve. Then in a Benedict syndrome, you're going to hit the red nucleus along with the ipsilateral. So you have an ipsilateral third nerve, and then you'll have this rubral tremor. So red nucleus, red, rubral, rubrospinal tract. So a rubral tremor is sort of the classic pathognomonic finding along with this ipsilateral third nerve. Then in a Claude syndrome, you have this, it takes place inferior to the red nucleus here. You have these decussating superior cerebellar tract fibers, superior cerebellar peduncular fibers, and then you also have the third nerve that gets hit. So you're going to have an ipsilateral third nerve injury, and then very confusingly, you're going to have a contralateral ataxia. So this gets into the fact that the cerebellum has ipsilateral innervation, but these fibers are coming from the opposite cerebellum. So they're coming from this side of the cerebellum here, so the ataxia is going to be on this side. And that's an important thing to pay attention to, is the fact that it's a contralateral ataxia with an ipsilateral third nerve. And then again, the key point is that this is below the level of the red nucleus. Pontine syndromes, there's two we're going to talk about, locked-in syndrome and dysarthria clumsy hand syndrome. We talked about these pontocerebellar fibers, this large pontine basis, and then these are these peduncles here, these cerebellar peduncles here. There's a lot of afferent and efferent fiber innervation coming from the cerebellum and relating with the pons there. So in locked-in syndrome, this has the appearance of patient being comatose because they're unable to move. But unfortunately, and this is a horrifying syndrome, the motor fibers are knocked out because they're contained within the pontine basis here, and they're injured. And then the injury extends, knocks out the facial fibers here, and then also the parapontine reticular formation is injured. Horizontal eye movements are affected, but vertical eye movements are typically preserved. And then there's also a relaxation eye blink that can be preserved, and so patients can be trained to communicate through eye blink, and it's actually a relaxation of eye blink. And this is the appearance of a locked-in syndrome, injury to the pons here. This was a stroke affecting the pons, and then this is the central pontine myelinolysis. Overly rapid correction of low sodium levels can cause this myelinolysis, this demyelinating phenomenon within the pons, and cause locked-in syndrome. Then this is dysarthria clumsy hand syndrome, a paramedian pontine infarct. So it's anterior, so it's affecting motor fibers, and it's medial, so it's affecting the face and arm. And then the leg fibers are out laterally here, so they're not affected. So it's just dysarthria from difficulty speaking, and then clumsiness from affecting the hand, dysarthria clumsy hand syndrome. So finally, medullary syndromes. There's two of them we're going to go over here. You can see these inferior olives. They stand out in this myelin staining cadaveric section. So the first one is Wallenberg syndrome. You can see this dorsolateral medullary syndrome. This is radiographic orientation, whereas this is anatomic orientation. Really important stroke syndrome to know well because it's super easy to miss. And here's why. It affects the posterior aspect of the medulla. So what's not affected? Motor fibers. They're typically anterior, right? So it's easy to be dismissive of a patient who walks in with a variety of symptoms but doesn't have any profound weakness. Weakness is easy to identify in physical exam, but you're not going to have weakness if you're affecting the posterior aspect of the medulla. Now what you will have is a variety of findings that you can learn cold. So spinal thalamic tract, meaning sensation from the opposite side of the body, is going to be affected. Spinal trigeminal nucleus is going to be affected, so sensory from the ipsilateral side of the face. Nucleus ambiguus in the solitary tract, so you're going to have dysarthria, you're going to have hiccups, is actually one of the potential manifestations of Wallenberg syndrome. Hypothalamospinal fibers, so you can have a Horner syndrome, ptosis, meiosis, anhydrosis. Vestibular nucleus and inferior cerebellar peduncle, so ataxia. So patients will complain about gait ataxia, odd sensory phenomenon. They may feel like they're having difficulty swallowing. They may have some dysarthria. And it's easy to miss a Wallenberg syndrome on clinical inspection. And then it's also easy to miss on MRI because oftentimes brainstem strokes won't really appear for the first couple of days. And because MRIs are slices and there's gaps in between, sometimes the stroke just won't be identifiable on the MRI. It's really helpful to know exactly where you're looking for, and it's really helpful to be confident knowing this various constellation of symptoms. Finally, Dejerine syndrome. This is medial and it stretches from the posterior anterior portion of the medulla. So what's going to be affected? The motor fibers in addition to the sensory fibers and the cranial nerve nuclei. And here's an example of Dejerine syndrome. So that's a whirlwind on brainstem anatomy. I hope you'll apply this brainstem composite approach, this grouping approach, as you learn these various structures. It's the best way to be able to anticipate the anatomy and reduce the memory burden that it requires to know this cold.